Let's begin. I'm Ashutosh Varshney, Director of the Center for Contemporary South Asia, and welcome to the fifth meeting in this series, the fifth seminar in the series, COVID in South Asia. And our guest speakers today are from India, as has been a pattern now for most of our meetings. Shamika Ravi will is speaking from Delhi. I think that's where she is. She is a senior fellow at the Governance Studies program of Brookings in Washington, but she's based in Delhi right now and is a visiting professor of economics at the Indian School of Business, ISB. Our second speaker is Ruben Abraham, who is CEO of IDFC Foundation and IDFC Institute, a think tank in Mumbai. And for a larger introduction, you can go to our events page where their various accomplishments have been summarized. But in the interest of time, let's move ahead. Shamika will give us a nationwide trends, however she wants to break them up. Over time, over states, over urban, rural. I'm not sure she's the master of that universe. Every single day, every morning, she sends us all a notification on Twitter or a broadcast on Twitter, actually, summarizing what happened in the last 24 hours and keeping us very well informed about the trends. And then in the last half hour, no, not the last half hour, in the second half hour, we'll have Ruben summarizing Mumbai, trends in Mumbai, which has become a hotspot, and I think is the biggest hotspot in India right now. And the plan is as follows. They'll present and speak for about 15 minutes or so. And then we'll open up for a Q&A with respect to their presentation, move to the second presentation, and the last half hour will be for a general discussion and in that half hour slot, we'll cover both presentations, and maybe both speakers can also speak to each other in that slot. So that's the plan. Let's start with, I know that some of you are joining in from India as well, from some students in my class, and some, of course, from Providence and some from the East Coast. So let's start with Shamika, and she has slides for us, and she'll share them.
Thank you, Ashu. Happy to be here virtually with all of you. I've put together a series of pictures, really. And I'll talk about each of them. Let's start off by first getting a sense of the magnitude of the problem itself. And of course, everything is conditional on the strategy that is being followed. Different countries have had very different policy interventions at different points in time. But it's good to look at everything in an aggregation to get a relative sense of the disease burden or the infection burden or the case burden itself. And here, if you notice, India is the green line at the bottom. Obviously, this is only comparing India to the hotspot nations which have more than 50,000 cases each. So these are mostly the OECD countries from Europe and it's the US. As you see, India has just crossed, it's a little under 35,000 as of this morning. There have been a series of policy interventions at different point in time, but you see that 35,000 is very low compared to if you see the US, which has crossed 1 million, if you look at Italy, Spain, UK. So the case load seems relatively small. If you look at the total number of COVID deaths, and again, compare them with hotspot countries. And here, hotspots are really countries which have had more than 3,000 deaths. So Belgium, for instance, falls in this category, while it's not in the first one because it doesn't have more than 50,000 cases. But it has had more than 7,000 deaths. And the number of deaths in India related to COVID have been a little over 1,100. So again, the death numbers also show that the relative severity, along with the case burden, is quite muted compared to the other hotspot countries. This is to give you a sense of the timeline of how things have evolved. And at an early stage, just like in the US case or the European countries, this truly is an imported infection. So what happened is very early on, and hindsight perhaps very smartly, while the first case of COVID was announced or reported in the last week of January across most of these countries, but India was extremely proactive, and I suppose it is because it's a resource-poor country. Prevention goes a long way for an economy which really has health infrastructure which is limited. So very early on, the Indian government started to airlift people from Wuhan, other parts of China, from Italy subsequently, and also from Iran, and kept them in camps, kept them separate from the rest of the population. So people weren't allowed to mingle when they returned from these places. So quarantine facilities were set up very early on. Thermal screening started at the airports quite early. Now, of course, in the news, we heard about several high-profile cases where people jumped these screenings or blatantly lied. And of course, just thermal screening is also a very basic, rudimentary way of screening for symptoms. But nonetheless, several steps were taken even before the case count really went into triple digits. Then what we noticed is around the 12th of March, again, very early on, schools and colleges were shut down. The Epidemic and Disease Act, which is quite a restrictive, it's a very old act, more than 100 years old. But what it does do is it gives state special powers to detain or separate people. Because the nature of infectious diseases is such that it's not just an externality, you're to the person who's infected, but increasingly you become a threat to others around. The infection is likely to increase. And so this disease act, Epidemic and Disease Act, became a sort of a necessity. And most states of the union did enact it very early on. Now, you begin to see the early stage, the growth was rapid. We were doubling every 3 days. That's the rate at which the growth was happening. Then, of course, a very large congregation was discovered around the 29th of March, and which really affected more than 16 states of the union. What you do notice, though, is that the nature of the national lockdown in India is quite stringent, but the impact of this massive, strict lockdown, you begin to see in about 12 to 13 days after this was enacted. And that is the nature of the virus. The incubation period is really about 10 to 14 days. So you begin to see impacts of policies after about 10 to 12 days. And you do see that from April 6th onwards, until which we were doubling cases every 4 days. So it was still a very rapid increase we were facing. From April 6th onwards, continuously, the growth rate has declined. And as of this morning, the active cases are doubling every 15 days. So there has been a considerable decline. The total number of cases, which includes recoveries and deaths, those are doubling every 12 days. Now, there are data sets and data sets. There are lots of different sources. But it truly is a miracle in some ways, because I've been looking at this data, all these different sources of data for quite almost 6 weeks now. And today is the first day when the ECDC data, the Johns Hopkins data, the WHO data, all give you the same growth rate. So in that sense, it's quite an anomaly, but it's convincing. This gives you a counterfactual. And this is truly for, just to understand what decline in growth rate means for an infectious disease of this nature. And you're seeing that when you double at 3 days, what would the counterfactual have been? How many cases would India have really had to handle? And that's over 12 lakhs. At about 5 days, we would have had, more than 1 lakh. At 7 days, we would have had about 51,000. And today, of course, we have under 35,000. This is, of course, if you keep the base as April 6th, from when the decline did start to happen quite consistently. This is showing the 7-day moving average. Now, beyond the day-to-day fluctuations, that's what, in fact, both these graphs show. On the left side panel, it's the caseloads, the daily confirmed cases, and on the right side, you have the daily deaths. Now, both of these, the long-term, we call the 7-day moving average a longer-term trend because you want to really smooth the noise of the day-to-day data. And you do see the trends are both, of course, showing positive, which means we are still at the growth phase of this epidemic, this pandemic. But the growth rate has been declining. And if you see the numbers in terms of the average daily deaths, it's under 50. But this gives you a sense of the mortality rate itself relative to the population. So per million, what is the number of COVID deaths that India is facing? And you see that India is really reporting 0.85 deaths per million people. Now compare that with the US, for instance, where it's a little under 200 deaths per million people, or the UK, which is a little over 400 deaths. Belgium, of course, is extremely high and still increasing. Many countries in Europe, however, have begun to show a stabilization. So it's looking like the death rates are stabilizing, except perhaps Sweden and UK. And Sweden, because it has the policy that it has, and UK, because the way they are reporting death, they had a massive jump yesterday when they reported 4,000 deaths, additional deaths just yesterday. And that's because now they've started to count death in, away from the hospital. So a lot of this, the nature of this data is such that different countries are counting things differently. But again, the idea of looking at these cumulative cross-country numbers is to get some sense of which way we are headed. One thing I'd like to point out here is that China has fixed its mortality rate at 3.34. This has not undergone any change in the last 1 week. So there has been a revision there. But we're also not seeing too many differences in terms of the case count itself there. Japan, today is the first day when Japan has really overtaken China's mortality number. So that's the reason why you also see that in Japan, while the new cases might not be very high, the mortality numbers are shooting up. And that is the reason why they've gone back to a national emergency after weeks of seeming success. But India is a very large country. And you're all familiar that 1.38 billion is a very large population to study in terms of national trends. So the action truly lies at the state level. This is showing what the total case count looks like and broken across recovered deaths and active cases across the states of the country which have more than 150 cases. Right? And here, if you notice, increasing band of blue is actually a sign of flattening of the curve. The gray bars are showing active, that is the current case load in terms of the infection, the way it is spreading. While all of India, which is the left-hand panel on top, is showing that there is an increase and it's pretty smooth because it's for a very large population. You do see that Maharashtra on top and Gujarat truly are still witnessing exponential growth, where the recovery, while it is increasing, but the case in terms of active cases itself is also rising exponentially. Those are states of great concern right now. If you look at Delhi, Delhi had some success, I'd say in the first, let's say 2-3 weeks back, we had active cases actually decline because recovery rates began to increase. But what you're seeing now in the last 1 week, in Delhi, we are really having a second wave, which is a much bigger wave because the active numbers have now gone up significantly. Madhya Pradesh is again adding a very large number. It's not exponential, but it is a cause of concern. It's a large state. Rajasthan, after initial big increase, you are seeing that the blue band is increasing, which means the recovery rate is improving in Rajasthan. Tamil Nadu is one of the states which has actually seen tremendous recovery, though the caseload on a daily basis is continuing to increase, but recovery in Tamil Nadu is quite strong. UP, as you can see, again, increasing very fast, but the blue band is also expanding. Andhra Pradesh, similarly. Telangana has started to flatten the curve, where you see recovery numbers are increasing at a fast rate, and active cases are in fact declining. West Bengal, again, still rising, cause of concern. Jammu Kashmir, recovery seems good. Karnataka, things are looking good. It seems that the recovery rate is expanding. Kerala has truly flattened the curve. If you see that the overall recovery is much higher than the active cases. Now, Kerala we still have cases there. We are still discovering new cases there as well, just as in every other state of the country. But these are relative terms in terms of how much control do we have over the infection currently. Punjab, in fact, looked pretty good for about a month. And then you can see they have had a massive jump in the last couple of days. What you will also see, and as we noticed today morning when one of the cabinet ministers from the Punjab government, he's basically blaming the lack of contact tracing and screening in Maharashtra. So he's saying people basically fled and jumped quarantine and then landed up in Punjab. Well, this is going to happen. I mean, it's not like, these are completely sealed borders. And we are likely to see these kind of cases happen across states of the country. Bihar still has a low case count, but you can see it's still exponential growth. Haryana, pretty much like Kerala, has again flattened the curve in terms of having very large recoveries. Their active case count has fallen dramatically over the last 3 weeks. So that's giving you a general sense of what the country looks like. This is the 5-day moving average of new confirmed cases. And frankly, this is what we have to bring under control, because this tells us that it's a combination. It's not just testing. I think in the common sort of a simplistic understanding of the infection, we think it's just testing, which is the constraint, but it truly is a combination of 3 factors. It's the containment strategy itself, which is obviously a district or even a block level, it's local administration. Then the contact tracing, which is a highly scientific, it has to be done very rigorously, where you go and trace people who have come in contact, the primary contact, the secondary contact. So there is a lot of debriefing that is required. You need to track people's call records to verify where they have been. Now you can imagine that most of these states, or across the country, I would say the public health HR, just the capacity in terms of having enough people to do that kind of exercise is very limited. And that is why we have been appealing to local governments across the country to really involve the police there. And I think that's one of the reasons why Haryana and Kerala, we've just put together a case study for Kasaragod, which is the northernmost district of Kerala. The police was instrumental in this because first of all, they have the manpower. And secondly, they are trained in debriefing and verifying and, the call records, verification, containment itself. So truly at the local level, you need the public health, the civil administration and the police to truly coordinate this containment strategy for it to be successful. But this is what it looks like in terms of new cases coming up. Look at Punjab, the bottom right-hand side corner. They've had a massive increase in terms of new cases yesterday. Karnataka just had a big spike. So yeah, this is still very much a dynamic problem. It's still unfolding. Too early to say anything beyond, let's say, overall national numbers. These are giving you the COVID death rates per million again across states of the country, which have more than 150 cases. Relatively low mortality in Kerala, Haryana, Uttar Pradesh, etc., etc. What you see is the all India average is about 0.89. Now, the reason you have 0.89 here and you had a little lower in the other, the international comparison is because that data set was the Johns Hopkins, which is what we use to do national level analysis. State level analysis, Johns Hopkins does not put out state level details for India. So this is from a crowdsourced, this is the tracker, the COVID-19 tracker, which is really an effort of a handful of very young, bright, entrepreneurial, high energy youngsters who really put this thing together. Ideally, it should have been coming from the government, but that is the state of data. It's Maharashtra, Gujarat, Delhi, and MP, which 4 states which are truly pulling up the national average, because the death rates in these 4 places are much, much higher than the all India average. So I'll end with that. That's to give you a sense of, you know, how things. Oh, I have a little bit on testing. Now, this is the confirmed cases per 100 tests. Overall, testing in India has been expanding. Some say not enough, but you know, given state capacity, and it has been rapidly increasing since the 27th of March, and it has only grown exponentially since. But in terms of positive cases per 100 tests, we have flattened around 4.5%, which means the infection rate within the population. Now, India has a very narrow protocol for testing. We are still only testing people with symptoms, people who have come in contact with people, or with travel history. So this is not random testing. In that sense, this should have ideally been much higher. The probability of actually striking someone positive when you conduct, let's say, 100 tests should have been much higher. In the US, for instance, this was about 15-16%. Italy was about 22%. So in India, 4.5 seems to suggest that the infection rate is quite contained. This is just telling you that same story over time across different states of the country. Different states are testing very different number of samples and people. But again, this repeats the same story, that it's Maharashtra, Madhya Pradesh, Gujarat, where the infection rate is high and it's still increasing. And that's the problem. But there are many parts of the country where it's quite low. Chhattisgarh, Jharkhand, if you look at Kerala, Haryana, Odisha, Karnataka, you know, these are all very low infection rates, which are under 2%. AP, under 2%, and it's falling. So those are good signs that the problem is truly not uniformly distributed everywhere. So the focus really needs to be on certain hotspots and not everywhere. This is the broader economic scenario. IMF has projected 1.9 as the growth rate of the fiscal year, which is a bit puzzling. They probably assumed a very large government spend. But the way things are moving, I would peg the growth rate to be anywhere between -2 to -3%. Very large number of people run the risk of unemployment. We have a number of about 40 million people, mostly in the informal sector. By the way, we might have a structural break in the way labor force participation itself is going to happen. India already has a very low labor force participation. Barely 50% of the working age population is either working or looking for work, which is very low compared to most emerging markets, including Bangladesh, Thailand, etc. Now, with the fear of the disease or this infection, people who are going back to, let's say, UP, Bihar, are unlikely to want to come back to the big cities immediately. So I think we're looking at a structural change over the next several quarters. This is telling you that, you know, it's not an all India problem. 30 districts have very large number. So those are truly the hotspots. We have more than 14 districts which have reported 0 cases. So very quickly we can confirm for community spread there, and ideally they should all be open. Life should go back to normal there. But normalcy, well, it is a new normal. We keep talking about that, which means self-protection, expecting, you know, mandating masks, mandating, you know, sanitizing hands, social distancing, physical distancing, all of those are the new reality. So I think with all possible precautions, we should definitely open up the economy in those parts where we don't have the cases. And elsewhere too, I would say even the red districts, it's not like all of Delhi has very high infection rate. Those are really blocks. And the reason I say this is because, you know, for an economy of under $2,100 per capita per annum GDP, we truly are a resource poor. We are a low middle income country. For us to be thinking like an OECD country is a bit problematic, because the opportunity cost of a lockdown in terms of the economy and livelihood is very high, and is likely to push millions of people who have you know, come out of poverty in the last 15, 20 years. There is great vulnerability at that point. So lifting of the lockdown becomes an imminent policy recommendation. Thank you. I'll end with that.
Thank you, Shamika. Remarkable overview. This is what we needed. Now, let me, let's say 10 minutes now for a discussion on this presentation, and we'll return to it after Ruben's presentation, as well as the plan was. So let me start us up by asking two questions. One is that all over the world, we think that COVID-19 has quite clearly tracked globalization. The more globalized a place, and therefore OECD countries, et cetera, and the more globalized a place, the greater the incidence of infection. And from that it follows, the second question is simply a follow-up of the first. It's also generally believed the more rural the place, the lower the incidence of infection, and the more urban the place, the greater the incidence. So can you comment very briefly on this as it applies to India? Bangalore seems to be, Bangalore among the most globalized cities. Bombay, we'll hear on a presentation, Bombay among the most globalized doing badly. Delhi among the most globalized doing badly. Bangalore among the most globalized not doing badly, it seems. And Kerala among the most globalized states of India because of migration, not doing badly earlier, but not now. But let's put Kerala aside for a moment. How do you respond to these these set of concerns?
So I agree with all your observations, Ashu. I think it's absolutely correct, but that's the nature of a highly interconnected global economy. I mean, you've had all the benefits of globalization, and I'd say India has been one of the beneficiaries of rapid globalization over the last 30 years. And we have not seen the kind of pushback to it, at least from the the political economy side of it, as you have seen in the OECD countries, Europe, and particularly the democracies, Europe and the US. But given the dependence, it's not just globalization theoretically, it's also the interdependence on China. And I think that poses a greater strategic concern for a country like India, because let's say pharmaceuticals, India has been called the pharmacy to the world, because we do supply about 1/5 of all generic drugs globally. And yet we are dependent on China for a lot of the chemicals, a lot of the inputs. So you can imagine that, and this is just pharma I'm talking about, there are many other sectors where we depend on China for the inputs. And I think moving forward, while we will gain from globalization, strategic interest of countries will demand, at least in the democracies, that there is a certain push towards self-sufficiency or looking at other markets outside of China to really lower the dependence. And we're seeing this, by the way, in Australia, we're seeing this in many other Asian countries as well. But in India, I think it's likely to be pretty strong. On the rural-urban difference, again, it's an extension of exactly this. Right now, it's an empirical question whether has the infection spread to rural India. If you notice, most of the green zones are in rural districts of the country. Because again, this is an imported infection. It remains in places, it's likely to be where the flow of travelers, labor was highest. And that's why you have Delhi, Bombay come up. And, but the spread is really not just a globalization issue. The spread issue has to do with the containment strategy, the contact tracing, and the subsequent testing that comes with it. And I think the variations that we are seeing in India today, the states that have truly controlled the situation have had caseloads. Haryana, Gurgaon is right here. They've had a lot of people fly in. But I think Kerala, Haryana have succeeded because the local administration, the kind of containment strategy that they put in place was very good. And we have to give credit where it's due. Local administrations in these places have put the contact containment strategy, the contact tracing, and the testing. So that goes beyond globalization. That just tells you the problem is here. How well do you manage it?
Other questions? I can see Patrick's hand up. Yeah, Patrick.
Thank you, Shamika. That was an amazing presentation. And thank you for all the graphs and data that you've been putting together and sharing on Twitter. I think I speak for everyone when I say it's been an incredible service to have the data so cogently and brilliantly presented and shared with us. So thank you for that. And all the trends you're looking at, do suggest that a deacceleration, and we're all breathing a sigh of relief. But I ask about the underlying data. I mean, testing in India is still abysmally low, 650 per million. Even in the US, you know, which has had one of the worst responses in the world, we're at 20,000 per million. And death rates, yeah, you'd think that would be a more robust measure. There isn't as much selection bias. I mean, with testing, there's bound to be massive selection bias, right? It's elites, it's people who have access, people who have knowledge, and you worry about the slums, right? Are folks in the slums getting tested? So then you turn to death rates, and that's probably a better measure by and large, except that, you know, we know even now we're discovering in New York City, you know, bodies in trucks that have been unaccounted for. And as you just mentioned, in England, they're now reporting deaths at home. And one really worries if there aren't, you know, a far larger number of deaths simply being unreported, deaths at home, or deaths that haven't been diagnosed, et cetera. So I know you've thought about all this, but I'd just love to get your reactions to how good you think the underlying data is. I would point out that, having followed the Kerala story carefully, there I don't doubt that the data is pretty good, right? Because there's such an intense presence of the state, the local state, the public health care system, the ability of the police and civil society to report that the data probably is pretty good. And so that would suggest that maybe the virus overall is not as bad in India as elsewhere. And then the final question is, you know, if it is not as virulent as it's been everywhere else, why? If anything, given densities, given the public health care system, one would have expected a Belgium-like situation, and yet we're getting, you know, something that's really off the charts and almost an outlier.
Yeah, and on the density question, I think we should return we should hear what Shamika has to say. But on density, we should have a discussion with specific reference to Bombay as well, right? Yeah. So let's hear Shamika, and I'll open up one more question, then we go to Ruben. I think William had his hand up. So Shamika, yeah.
Yeah.
Arushi also. Okay.
Thank you, Patrick. All absolutely valid concerns. I think in every country, including Germany, we have a paper coming out tomorrow on trends in Germany. Data remains a concern, Patrick. Data remains a concern everywhere because state capacity right now, I think there are very few countries which have the state capacity to even forget about testing capacity and the political economy around that. But just putting data together in a way that researchers like us can take a look at it, which is more public interest in nature. Most countries, I think, are falling short of what ought to be the standard. But I think that is where I think we are putting too much focus on testing itself. And that's because, and that's why I think it's important to realize that, containment strategy right now becomes, containment along with the contact tracing becomes as important as testing. Because imagine Kerala, when they had a case count of about 100, had done, this is in Kasaragod, well, all of Kerala, but in the beginning, I'm just going to talk about Kasaragod because we've written the case study on it. They had done contact tracing of over 20,000 people within Kerala when they had a case count of 100, under 100. Compare that with Bombay, when they had a case count of under 100, just under 100. The contact tracing done there was under, it was about 6,500. Now that just tells you that contact tracing is, it's impossible to do random testing for 1.38 billion people. I think those are the natural constraints for a resource poor country that we have to begin to accept and appreciate. And that's why the national lockdown becomes such an important strategy despite the huge economic cost. So there is testing part of it, but I want to emphasize the contact tracing, why it's as critical. But then, on the mortality, we have also been looking at hospital level data, Patrick. And if you look at, we have data for about 100 hospitals across the country, which are more than 100 bedded hospitals. And we are seeing that the number of patients coming in with acute respiratory syndrome, ailments, are looking very similar this year in the months of February, March, and April as they did last year and the year before that. So there is reason to believe that what is being reported from across the states might actually be true, in the sense there is no great hospital rush happening anywhere. There might be isolated cases. It's a very large country. But on the whole, the trends seem to suggest that things indeed are. It's not just the caseload, but also the virulence does seem to be under control, relatively.
I think I had William and Arushi. Can we have both of you successively in the interest of time, and then we have Shamika respond to you. So William, will you go first?
Yes, so thank you so much for your presentation.
William is a public health student, graduate student.
Yeah, and I do behavioral social science with EPI as well. But so I thought, I know you talked a lot about containment, but what I'm kind of interested in is kind of the lift of the lockdown, right? So if the strategy is kind of, if your suggestion for the strategy is more looking at hotspots in districts, how would you control for just behavior, right? Like people are not going to kind of stay in containment, such as like there's going to be movement, you know? And so if the strategy is more at a district level and at a hotspot level, how do we think about people's attitudes and behavior patterns with the lift of like a kind of a calibrated way of lifting the government?
And Arushi, your question?
Yeah, very similar actually. Yeah, I mean, I'm doing my PhD in economics here. Very similar to William actually. My concern was about the counterfactual graphs that you showed us. I mean, I'm wondering what is pertinent maybe from a modeling perspective right now is the, as you said, the imminence of the lifting of the lockdown. So I'm wondering if you've been able to model just what those graphs would look like once the lockdown lifts. Because this can't go on. I mean, the containment in this, it may not be representative of what is going to happen.
Yeah, great, thanks, excellent questions. You know, William's first. William, there is a concept, and you're probably familiar with this, of elasticity of demand for self-protection. We are all going to be much more careful, regardless of state policies. We are going to wear gloves and wear masks and not hug and probably do more namastes or whatever it will be. But physical distancing is the new norm for the next few years, right? There is also a great fear of the unknown. And I think the fact that there is so little information out there in the public domain, people are very, very afraid. So every time they've done a survey of what do you think should happen with the lockdown, overwhelmingly, I mean, there's the business side of the story, and the economist in me worries a great deal about continuing lockdown. But people support it. And that's largely also on account of the fear of the unknown. The fact that we have not got detailed data for India, which says, you know, the kind of JAMA study, which came out saying 80% people will not need any intervention. Of the 20% that will need, only 5% will truly need hospitalization of an ICU nature or a ventilator, etc. Those are not based on Indian data, William. Okay, so again, and this is happening largely because we don't have localized contextual Indian data to base our premise on. So we're going by what we are hearing in other countries. That's number one. On account of the modeling, it's exactly a Rushian extension of the same. That, you know, the EPI models, the reason we started doing this statistical analysis every day is because the EPI models are all assuming parameters from early stage in China, or the Diamond Princess, or let's say early stage Germany. The predictions for India were 600 million people, 500 million people are going to be infected. Those are fantastical numbers, but if you look at the parameters, they are not valid for India. Now, you really need to estimate. It's not about guesswork. You need to estimate what should the R naught be. What is the level, what is likely to drive the infection? I would say Kerala and Punjab are going to have very different, the social norms are different, weather is different. So you are going to, or maybe perhaps even innate immunity, who knows? But you need to estimate those parameters at a highly localized level, or at least separately for India, to then use these models. So we said, you know, let's put aside the EPI models because we don't have knowledge of parameters for Indian population. Let's look at statistical analysis of existing trends. And we have noticed that the expectation of the infection rate, it should be exponential. But from April 6th onwards, it is seemingly linear. And that's where you begin to believe that, the suppression strategy of such a stringent nature becomes, it's effective. Of course, it's very costly, but it is effective. Now, when it is lifted, it will be a combination of everything, William. Nobody is going back to life as it were. So I think it will depend on the exact enforcement at the local level of how firms are going to enact. Firms are going to expect social distancing. You're not going to have so many meetings, mostly virtual again. We will, even at the factory, shop floor, we will have distancing. We'll have people wearing masks and gloves, etc. So a lot of it really becomes an empirical question. Moving forward, let's wait and see. But it's important to lift the lockdown simply because, it's a virus. We don't have a vaccine. The death rate is low. The caseload is low. It's too heavy an economic price for a poor country. So let's break a few eggs to make the omelette. Let's see as, we'll work on it as it goes along and much more localized, not national level. Thank you.
Thank you, Shamika. Let's move to Bombay now. And Ruben has some fresh data that no one has seen before. So Ruben, you put together your slides and we now analyze, we look at the biggest hotspot of India.
Sure. So before I start, I just want to caveat the fact that I'm not a healthcare person. Our focus has been state capacity. And so therefore, from a state capacity perspective, this entire thing has been really, really fascinating. And the problem that we've had in Mumbai certainly is that we've actually had no data. And the data is all contradicting each other. Even the number of deaths seem to be contradicting each other. And so on. So, but I managed to convince somebody at the Bombay Municipal Corporation to share some stuff with me, and that's what I'm just going to quickly show you.
You will share your screen with us.
Yeah.
There you are.
Can you see it now? It's good?
Yeah.
Okay. So, so before I start, I just want to just give some context in terms of, why we got involved with this to start with. So we were we do a lot of state capacity related work in Kerala. So about 6 weeks back, Kerala called us in to help them do some modeling work for them. And it became very, very clear to us very quickly that that Kerala was literally light years ahead of anyone else in the country in terms of the kind of protocols they'd already put in place. Now, keep in mind, now this is a trend that you'll see worldwide, which is that countries and regions that have had a previous experience with a pandemic-like situation respond much better. So you look at Taiwan. Taiwan basically put systems in place on December 30th. Kerala, because of its experience with Nipah, had actually got a whole range of systems that were in place 6-7 weeks ago. So so I remember 5 weeks ago, they showed me their funeral management protocols, right? And it's a very detailed funeral management protocols that they put into place. So that was the level of thinking that was going on there. And also it became clear to us that the rest of India at some level had not gotten it down to that level of granularity. So one of the things that we did very early on was to actually create a process document of everything that Kerala had done. So we had basically created a 26-page version, a 15-page version, and a 3-page version, and we offered it to states. And as you can imagine, Ashu, most of the states that we gave it to basically ignored it. And they ignored it basically saying, Kerala has the largest number of cases, right? And they weren't actually thinking about the strategy that Kerala was employing. They were just looking at the caseload. So if you look at the strategy was Kerala had very clear ideas in terms of they did not want people to come to hospitals. They want only critically ill people to come to hospitals. So they had basically architected a system that sort of responded to that. So in effect, that's where we came from. And we basically set up a sort of track 2 effort. Shamika is part of it as well. And that track 2 effort has now actually grown fairly dramatically. I think we've got about 140 experts backed by about 60 to 70 researchers and a modeling team at MIT and Chicago that are basically backing this effort. It's broken down into 20 subgroups. So subgroups ranging from supply chain management. We've got subgroups looking at law and order. We've got subgroups looking at data modeling. and so on and so forth. So a lot of what I will really contribute is from real world, actually looking at, and you know, to be fair, a lot of what we've done is just firefighting, right? So containers getting stuck at JNPT at the port, and how do we basically get the containers out? That sort of thing. So I can lend a lot of sort of practical stuff that we've seen as well. But let's just first look at Mumbai and Maharashtra. So Maharashtra obviously has the largest number of cases in the country. I think the latest number was approximately 10,500 as of yesterday, confirmed cases. The blue is the daily deaths. Shamika has already talked about the fact that mortality in Maharashtra and in Bombay seems to be very high. We don't really know why that is the case. The graph at the bottom is the top 5 districts. Mumbai is the blue, and the yellow is Thane. So, and there's another district there which is Palghar. So 3 of those lines are Greater Mumbai. So if you just look at Mumbai, Mumbai has more confirmed cases than the second state in India. So Gujarat is number 2 on the state count, but Mumbai actually has more cases than Gujarat does. Okay. This is just giving you daily number of positive cases. You know, it's just basically yo-yoing at some level. Yesterday it was about 417 cases. One of the things that people in Mumbai, certainly in the government, believe the reason for why you're seeing a lot more confirmed cases in Mumbai is because Mumbai is also doing a lot more tests. So this is basically Mumbai compared to other states. So clearly Mumbai is doing way more testing than any other state, leave alone any other city. So that's something to sort of take into consideration. These are active cases, recovered cases. So again, Shamika has gone into most of this. So I won't, I'm just wondering if there's anything here to really point out. No, there isn't. This is an interesting one. This is, so, you know, we've always considered COVID to be a disease that really affects the elderly. But if you look here, so yes, the deaths are still mostly happening in age groups above 50. But if you look at both the confirmed cases as well as deaths, so certainly confirmed cases, there's a lot happening under 50. And also the number of deaths, it's not an insignificant number of deaths that are happening under 50. There are quite a large number of people dying under 50. Again, why this is, nobody really knows. Now, one of this could just be that, you know, respiratory health in general is very, very poor in the country, even among the young. So I mean, we don't really know what is going on, but this was something that really sort of stood out in terms of something that was really unusual happening in Mumbai. Shamika, I don't know if this same, you see the same thing across the country, but this was really fascinating that there were so many more cases amongst supposedly a healthy population. And then this, I think this is probably the most important slide to show you. This is, we've just broken it down by wards. And I think this is the data that is most important. So it just basically shows you, you know, the darkest wards are basically the most number of cases. So if you look there, the 2 wards in the middle, I can't really see what those are, G, S, and something else. Those 2 are basically where all the slums are. So Dharavi, Kolivada, all of those are basically in that area. So it is becoming very clear. So for instance, I live in HW, which is not really affected. So going back to a point that Shamika made earlier, I think we need to start being a lot more nuanced about our sort of lockdown strategy, especially in these humongous cities, because to treat all of Mumbai as one, when you can see this huge differential, I don't think makes any sense. So in effect, it is slowly becoming clear that it is a problem that is in the slums and in the chawls. Now, you know, one way to think about that is think of the Diamond Princess and think of Dharavi, right? I mean, so it's probably a good proxy to think of, except that people on the Diamond Princess had access to individual toilets and probably were less dense than Dharavi. right? So if the rate of the prevalence on the Diamond Princess was about 20%, I think we should probably assume that 20 to 30% is probably the prevalence in places like Dharavi. Now, because we aren't doing any random testing, we don't actually know what's actually going on. But I think it's fair to assume that about 30% in the slums and chawls, there's probably that sort of prevalence, which then leads you to ask the question of what should we do? And I think in places like that, I don't think there's any point doing things like contact tracing. I think those areas are on a path to managed herd immunity. I just can't imagine what else we could do in these places, because you're not going to be able to ask people to maintain physical distance when they're basically living 6 and 8 people in 200 square feet. I don't think it's possible. So what is the solution? And so given the low mortality rates, now again, this is a number that we've been trying very hard to get, which is to see if there's a way to break down mortality by wards. And that unfortunately is not available. But I think in terms of what we need to do in the slum and chawl areas is something that needs to be considered very seriously. And I'll stop there.
Thank you, Ruben. Once again,
sorry, if you just want to see the contact tracing, yeah, those are the numbers.
Okay. First of all, I've already received a lot of requests. So requests asking me whether Shamika and Ruben can share their slides with us.
Sure.
And I hope you will be able to, because these are systematic. This is systematic data, nationwide, statewide, and then now breaking down Mumbai into these wards and trying to see where the largest incidence is. But one question for Ruben. Ruben, you on your slide, which said age structure of those infected, you also had gender there, or did you not?
Hang on a second. Yes, there was gender. Yes.
Is it like elsewhere, mostly male disease, or are you getting very substantial female infections as well? And then I'll ask Shamika to comment on this. Yeah.
Sure. So if you look at 21 to 30, yeah, 47% is female. That again seems an anomaly to me, but I don't know what the national data on this looks like. But that really does sort of stick out, is that 21 to 30, almost 50% is women.
In the 21 to 30, in the healthiest.
Yes, exactly. And then if you
go, half of those infected are women.
Yes, and then if you go to 71 and to 80, yeah, again 45%, 41%, 45% are women. So I mean, it's certainly an anomaly compared to global numbers. Yeah, I don't know what it's like compared to other numbers in India.
Shamika, any comment on that? Have you seen it yourself? I haven't looked at gender-wise breakup in India, but I can tell you that from Germany, that's the paper coming out tomorrow. There is, women over time have become majority of the cases. But if you look at the mortality numbers itself, there is a large and increasing with time gap between men and women. Men are much more likely to succumb to the disease, and this is across age groups. Across age groups. So a very clear distinction to be drawn between infection rates and mortality rates on the gender question. Absolutely. At least from the German data, Ashu, by the way, it goes back to a lot of the medical literature which links it to either smoking, but of course in Germany that difference is not very large as in China. People have talked about innate immunity, saying women have higher immunity to some of these viruses. So there are multiple reasons, nothing very, convincing right now. There are many things out there. Okay. So let's open it up. Who would, yes, I can see Patrick's hand again. Yeah, Patrick, go ahead.
Thanks, Ruben. That was fascinating. I have a ton of questions for you about Kerala, but maybe I'll take those offline and send you an email. I'd love to hear more the work that you and Shamika and these other teams are doing. It's totally fascinating.
And before we went online, Patrick, before we went online, we heard that both Ruben and Shamika are originally from Kerala, incidentally.
No, I know. And there's, I agree, there's a story about not only state capacity, but public action there, because it's about co-production with civil society, right? I mean, you can have a lot of police officers and you can have a lot of good bureaucrats, but if you don't have compliance from citizens and willingness to step forward, but I'll take that conversation offline.
Can I just respond to that, Patrick? I think it's a very important point that you're raising, because you see, in a lot of other places, this has been treated purely as a law and order problem.
Right.
Because the minute you treat it as purely a law and order problem, you get an us versus them response.
Absolutely.
What you need is an us versus the disease response.
Absolutely.
And I think that's what Kerala has done brilliantly, precisely because of what you just outlined. Yeah,
I mean, I've quoted the chief minister as saying this is not a law and order issue. This is about people's participation, which is a 30-year-old call to arms in Kerala. So, but I want to come back to your point about the slums of Mumbai, and I'm not sure whether this is good news or bad news. So, just doing some back of the envelope calculation. I mean, the slum population in Mumbai is roughly 50%. That could be 6-7 million people. 20% of 6-7 million people is an awful lot of people. And if the fatality rate is even on the lower end of the estimates, we could be talking about tens of thousands of people dying. Given your estimate that it's 20% in the slums who might have contracted this. Apparently, that's
again,
not
Patrick, can I just clarify, just to be sure, you have to take into account asymptomatics. So a very large number of these could just be asymptomatic. So in Maharashtra, again, just to give you the numbers on that. So, and again, these numbers are flying all over the place. But generally speaking, the assumption is that about 80% of cases in Mumbai are asymptomatic.
Right, but still, those are 20% of the slums in a city that's 50% slums and has 20 million people is still an awful lot of people. And whether you take a low or a high end estimate of fatalities, it could be a lot of fatalities, but apparently it isn't, which comes back to something Shamika and you have alluded to, and hasn't been discussed a lot, but maybe there is a story about immunity systems here, that the Indian population, for whatever reasons, and I know there's no solid evidence of this yet, but there's just such a discrepancy between, the numbers that were expected and the numbers that we're actually getting, even if there's some underlying data problems. Because I think you're exactly right. I mean, Ashu and I have been doing survey work in 15 Indian cities, and the percentage of people in the slums who don't have access to sanitation or water is actually much higher than the census data, and it's crowded conditions and people have extensive social networks, et cetera. So for all the reasons you said, you would expect this explosion of the virus in slums, and yet apparently that's not what we're seeing. So I'm a little mystified. I don't know if this is good news or bad news.
So, I mean, look.
Go ahead.
No. So, I mean, the way I would look at it is if we can move to a managed herd immunity strategy in containment zones, I actually think of it as good news simply because this is how epidemics die out. So it's my problem is it's not clear to me what else you're supposed to do, because pretty much the only thing you can do at this point of time is to make sure that the high prevalence remains in the containment zones and that it does not escape from there. But what do you do about what is actually happening within the containment zones? I'm baffled. I mean, to your other point, I mean, so you've got theories about BCG, you've got theories about, hydroxychloroquine, you've got theories about heat and humidity, immune systems. It's just hard to tell what's going on. But by the way, there's also apparently a paper in the works that talks about viral load, and that this particular strain in India apparently has a lower viral load than elsewhere. Now it's in the works. I don't know when that paper is coming out.
But MIT I haven't yet seen it, but it's been cited a lot. I have not been able to read it. Apparently, there's an MIT study pointing to temperature as
Yes.
a key variable. It's a multivariate equation. So, but a very high coefficient they would like to put on temperature in that multivariate model.
So
I have no idea. I have no idea how you would like to react to that.
So certainly I do think that there is a connection to temperature, but then you have to worry about a potential second wave, because remember, our flu season is the monsoon.
Right.
So in the paper that we are working on, this is a separate paper. This one really looks, latitude comes out as a very strong, explanatory variable. And latitude, I presume, humidity, temperature, many things go into that. But latitude is a very, very strong, explanation for the caseload itself.
I see. Other questions? Other people who would like to ask before? I don't want to be asking, Patrick and I shouldn't be asking all the questions. All right, so let me proceed further. The concept of herd immunity. Can we discuss this a little bit more? Some people argue that the so-called herd immunity develops after 60% in a given denominator are infected. And some people say about half of them infected, and then and that anyway. But wherever you draw a threshold of 30%, let's say, or 20% in Dharavi is going to be quite high if most people are not asymptomatic and don't have low symptoms, right? So can you just say a bit more about how you understand the idea of herd immunity, which several people are playing with? It's not just, and the claim that in poorer societies, in low-income countries or low-middle-income countries, you would not have the OECD style of testing possible. And even here in the United States also, it's not happening that much. Rhode Island, where I teach, is now apparently has the highest testing rate in the country at this point, which is very interesting. But give us, both of you, give us your thoughts on herd immunity and its application to India and or Bombay.
So frankly, I don't know what the herd immunity literature is telling us, particularly, for this particular virus. But given the number of uncertainties and the kind of uncertainty we are dealing with in this infection, the Dharavi example becomes interesting because, even in Singapore, after extremely well-managed situation for months,
exactly,
they've had to go back to a national lockdown because of a very large number of, relatively poor people in the hostels. These are mostly, labor. So these are camps. Now, wherever you have such high density of living sort of condition, you're likely to see this. But I think the Dharavi example also tells us, Ruben, that the state doesn't have to always, home quarantine is not necessarily the right way to move. I mean, Bombay does have lots of schools and colleges. We have a lot of facilities for public quarantines. Maybe people should be moved out. I mean, the fact that we're trying to keep all these people, and I've been told this often, that, don't compare Kasaragod in Kerala with Bombay because Bombay is different. Now, frankly, I don't know what is Bombay's contact tracing or containment strategy specifically. I'm not talking Maharashtra. Bombay. You see, when we wrote up the case study for Kasaragod, it was very clear because we spoke to different pillars of administration and everybody knew exactly what their role was. There was no turf war in the sense everyone had very clear instructions and mandates drawn out and people knew about it. So the civil society was mobilized in the reference that Patrick made earlier in exactly the way the administration wanted it to play its role. A lot of confidence building exercise, Mohan Lal was brought in a superstar, a movie superstar. He went out and gave a lot of messaging. Now, I think, Dharavi has to be dealt with from a similar strategy of saying, look, we have to do aggressive testing and contact tracing, but let's not think of containment as, being limited by this particular infrastructure of the slum. Perhaps people who have been tested positive can be moved to a public facility. I don't know what the situation there is, but clearly the way the numbers, and it's not just Bombay, right? I mean, we know that the numbers are increasing in Ahmedabad as well.
Correct.
And Surat and Pune. Pune also surprisingly has very high mortality, so I don't know if it is the age factor or what is it that is playing that role there. But I do think that not having a clear strategy is affecting the way the infection is spreading in these specific cities. So I don't think we should let go of the local administration so easily. I do think there is something amiss there.
So Ashu, let me just quickly on the question of herd immunity. So for influenza A, it is typically assumed that if you have prevalence, if you get to about 50%, then you develop some sort of herd immunity. With this virus, we just don't know what the right number is. So it's actually very hard to tell.
What's the number for influenza again? What's the number for influenza again?
It's about 50%.
50%. Okay.
Yeah. On the question of quarantine and the protocols in Bombay. So, by the way, I think this is part of the problem. So right now, the way it works in Bombay is that if you basically test positive, whether you have mild symptoms, you're asymptomatic, it doesn't matter, you're transferred to a facility, right? Now, I think that just unnecessarily loads the system. Instead, you could just use some simple heuristics and you basically say, look, if you have access to a room and a bathroom, right? An independent room and an independent bathroom, you can home quarantine as long as you are basically either asymptomatic or mildly symptomatic. Which, by the way, if you have that, you also encourage testing. You can get more people willing to test if you actually have that. Right now, everybody gets moved to a quarantine facility. Instead, what I'm saying is you can actually take off the load off the system by actually sending people to quarantine facilities who are typically people who can't maintain physical distance. I think those are the people who should actually be in a quarantine facility. Now, having said all of this, the good news is that Bombay is also ramping up its surge capacity fairly dramatically. So they're expecting the virus to peak in the city by, say, mid-May and a little after, by which point of time they expect to have about 75,000 isolation beds.
I see. The one more hypothesis and your thoughts on that. When we think of very low numbers in India, a hypothesis that people are proposing, at least here outside, is that India is exceptionally young as a country, and with 70% of the population below 35, or what is it, below 30, and the incidence, at least the international data suggesting that this infects the older populations much more. Look at the nursing home story in the United States. I think Patrick was giving me some data the other day. It could be something like 1/4 of all deaths in United States, or maybe
in Rhode Island it's 2/3.
In Rhode Island it's 2/3. A nursing home story. So it's on the BBC yesterday I was talking about care homes, what they call care homes in Britain. They're also, the incidence is exceptionally high. Now, do you find how do you react to this idea that since India is exceptionally young compared to other countries, it is not even, it's not going to get very high aggregate rates of infection?
Yeah, so very quickly, it is true that we have a different demographic structure, but again, going back to what I said earlier, keep in mind the fact that even young Indians have very poor health. So, you've basically double the rate of heart disease as Italy. You've got the highest prevalence of respiratory illnesses in the world, home to 1 in 6 people with diabetes. Then you've got other stuff like we basically have multi-generational joint families. There's all this other stuff also going on that we need to factor in. So yes, it may be true that our youth plays in our favor, but there's also complicating stuff out there.
Shamika, any your thoughts on this?
Well, you know, relatively, yes, we are a young country, Ashu, but we have over 150 million people above the age of 60. So there is a large population. But I think Ruben's point of comorbidities is, I think, extremely important here. India has very high NCD incidence, non-communicable diseases. And those comorbidities, at least from the literature, the medical science side tells us that people with comorbidities tend to have, you know, be much more vulnerable with these kind of infections. But again, I mean, that can only explain the caseload. I wish, you know, we had patient level data to really understand that who are the people amongst the ones infected in India who truly need this kind of intensive care. Again, that number is very low. Very few people have required ventilators and ICU support. So yeah, I mean, we are really reading tea leaves right now.
I see. And there's one more, this is necessarily speculative, but still I think the speculation can be based on some prior analytic base. How do we understand the question of whether there will be a second wave of infections in India? How do we understand that? So peaking in Mumbai mid-May, it has peaked already. Shamika, aren't you suggesting that's peaked nationwide as far as the aggregate nationwide data is concerned? Some states, yeah?
We are still in the growth phase.
We are still in the growth phase.
Kerala, Haryana and Tamil Nadu. Those are the three states where we have seen a reversal.
I see.
Now, nationally, it's still growing, and I think it will grow for a couple of more weeks.
Couple of more weeks. And then you are expecting a plateau and then decline, and then at some point, what people are calling a W effect as opposed to a V effect. A W effect with a plateau, not a point at the top, but a plateau at the top. How do we understand something like this? Singapore apparently is going through a second wave. So how do we understand something like this?
I think there are so many different factors that are going to determine the second wave. One is, of course, the flu season itself. I mean, and this is something we're hearing for most economies. I don't think India will be particularly an exception there, but within India, we have noticed Delhi is currently going through a second wave and a much bigger wave than the first one. I mean, we had relatively, I mean, despite the initial numbers that exploded here, we had 2 weeks of relative, good suppression. The active cases were coming down very sharply and the recoveries were rising. And we have seen in the last 5 days or so, the active cases have started to increase and now much more than they were in the beginning. So it is going to be a combination of, again, those three things: the containment, the contact tracing, and the testing. Now, if you throw in the monsoon season, once the lockdown is lifted, how are people going to respond? Are we going to go back to gatherings? And so this is very much an empirical question.
Ruben?
Yeah. No, that's fine. I think Banu has a question. He has his hand.
Banu, do you have a question? I can't see you. You are okay. Now I can see you. Yeah, go ahead.
Thank you, Ashok. Thank you, Ruben, for your presentation. My question is essentially on Mumbai. Unfortunately, experience tells us that the kind of information that you have can only come via BMC. And I wanted to know more about what Mumbai is doing in terms of the COVID-related response. Specifically, what we know of Mumbai is that the Mumbai Corporation is, budget-wise, financially, legislatively, has the sort of a big domain. And my own understanding is that BMC handles health, public health for the entire city. So when it comes to COVID-related responses as well, is it Mumbai or is it Mumbai plus the Maharashtra government, which is doing Mumbai COVID-related responses? And the second question is that it wasn't very clear from your presentation. Now, it seems like what newspapers have reported, GS ward is the one which has had highest number of cases. But the fact is, GS ward isn't just informal housing or slums. GS ward has other sort of various kinds of housing types as well. So would it be right to suggest that containment zones are, essentially, is there more granular data available to suggest what these containment zones are, or what kinds of housing types do they exist in?
Sure. So very quickly, and maybe I can tie this with what I wanted to say earlier when Shamika was speaking, which is, I think, quickly, Banu, the quick response is it's BMC that handles most of the response within the realm of the Municipal Corporation of Mumbai. Now, keep in mind, there are other municipalities in the greater Mumbai region who are not sourced, they don't have the resources as a Mumbai does. So Ulhasnagar, none of them actually have the capabilities. So that's the caveat. But certainly within the main part of the city, it is BMC that is driving the response.
Is Thane under BMC? No.
That's a separate municipal corporation.
Separate municipality altogether, right? Okay.
Yes, exactly. In terms of your question about, okay, let me just go back a second. Yes, it is possible that we will get a second wave and so on, which is why I think the only thing we should be focusing on is to build the surge capacity. And this is what Kerala has been focused on from day one. And by the way, even today, if you look at the excess capacity that they've built, and they're doing mock drills, right? Last week, I participated in three mock drills with actors as COVID patients, right? And they're integrating the entire IT platform, and they basically are reporting 2 cases a day, 8 cases a day, that sort of thing. But the amount of surge capacity that they're building up, which is, I think, what most big, certainly hotspots should be doing, at least until the vaccine comes. So I think that's
is that because, sorry to intervene, is that because, but I think we lose this important point, is that because a lot of Keralites from Malayalis from the Middle East are likely to return now? Is that's why the surge capacity has to be up to the mark? Yes?
That's definitely one reason why they are keeping that kind of surge capacity in place.
Right.
But also, even for that, the kind of protocols that they've already put in place on how to deal with the Malayalis who are going to come back. Protocols in place. So, by the way, these protocols were in place earlier. So, in terms of the way the database works, which is it merges immigration data, flight manifests. So, Kerala was the one state where you could actually find. So, if it was an Emirates flight coming in from Dubai to Kerala, they didn't want to know that piece of information. They actually knew where you were originating from.
I see.
Right. So, they had actually integrated all of that into their dashboard that they've maintained. Right. So I think surge capacity and building surge capacity is the critical piece. And so, whether it's basically using real estate facilities that are completely unused today, there's a whole range of things. In Bombay, the biggest piece of surge capacity is our indoor stadium, has basically been completely repurposed to be a isolation facility. So I think that's the sort of thing that we need to do. Banu, in response to your question about GS ward, yes, in the ideal world, absolutely. So, I mean, GS ward, keep in mind that entire area is also where some of the most expensive residential real estate in the world is. I mean, leave alone in India, right? But they all now fit into, so Malabar Hill also falls into some of those wards, right? So the problem is, where's the granularity of the data? So if I were to think about it, I mean, this is just a thought experiment, right? If we could actually have data by zip codes, I think that's the sort of thing that we should sort of look at to basically fine tune our response. Right now, the response is Bombay is a red zone. That's just not helpful. It's just not helpful.
Shamika, any comments on that?
No, agree with everything that Ruben has said, as always.
Other question, I think Patrick's hand was up too. Okay, yes, sir, go ahead. Yeah, let me see, who's it? Akshan, yeah, go ahead. You're sitting in Mumbai, aren't you?
Yes, yeah.
Zooming from Mumbai. Akshan is our undergraduate student. Go ahead, yeah.
Good. Yeah. So I wanted to bring another dimension into this discussion, if that's okay. I think it was touched upon a little before, the opportunity cost of the lockdown, in particular for Mumbai, and how you think, how has the state been able to leverage their state capacity to protect low-income and migrant populations, like the most vulnerable populations? And, if there's something you think they could be doing better.
I mean, look, so again, that's a relative question, right? I mean, what's your comparison? Right. So is Mumbai doing better than some other places in India? Yeah, for sure. But is it doing as well as Kerala? Absolutely not. So, I mean, you constantly hear of stories of people not being able to access food, the cops having a very sort of heavy-handed response in certain cases. People say vegetable vendors going out and the cops going and beating them up and things like that. And by the way, because it's an important point, let me just pivot on that for a second. And I think this is something that India needs to get down, which is our communication strategy is just useless. I mean, to put it mildly, right? And so therefore, whether it's from the state capitals or the national capital, all you're seeing is basically notifications and then clarifications to notifications, right? And then clarifications to the clarifications. Right? Now, the problem is, so as far as they're concerned, and I don't blame them, as far as they're concerned, they've done their job, right? You flag an issue to them, they have resolved it. Now, the question that you have to ask is, how is this message now going to the front line? And very often you see that this message is not transmitting to the front line. So for instance, the directive very clearly says that food delivery is okay. But then in the early days, food delivery boys got beaten up. Right? So I think this communications piece, which I don't think people talk about enough, but I think whether it's ease of doing business or it's basically something like a public health crisis, we have to improve our communications architecture. So a lot of what you see in Bombay in terms of bad experiences have actually been caused because I mean, look, again, I don't blame the front line necessarily. They are taking on enormous risk to be where they are, right? So at that particular point of time, if there isn't a clear channel of communication, etc., yeah, I mean, expect some bad stuff to happen on the front line.
Okay, 3 minutes left. Only one question perhaps now, and only brief responses will be possible. The question that nobody is paying a lot of attention to, some attention now in India in the newspapers. How do we understand the more recent Gujarat spike? Why is it the second biggest set of infections now after Maharashtra? Brief responses from both of you, Shamika and Ruben.
Well, I think the reasons are the same as Bombay, Ashu.
I see.
And I do think, in hindsight, in terms of a lot of the early policies of air travel ban, etc., I think the one big miss was that India allowed travel from the Middle East until much later. And the two states which are very closely connected with the Middle East are indeed Maharashtra and Gujarat. There's a lot of flow of people. And but of course, once that has happened, eventually it is the containment strategy, the contact tracing and the testing, this whole package. How well is the local administration able to implement it then becomes very critical. But the caseload in the beginning, I think, is largely on account of travel from the Middle East.
So, so very quickly, anecdotally, I just heard today that the walled city in Ahmedabad is beginning to start looking like the GS ward in Bombay.
Uh-oh. I see.
I don't have the data, but this is what I just heard today.
Right. I think I speak for everyone when I say this has been a truly remarkable, thought-provoking and enlightening virtual seminar. So thank you, Shamika and Ruben, for what you gave us to think about, to reflect on, and I hope you will share your slides with us. There are 3 more requests that have come on the chat through the chat function. I hope you'll do that, and of course we'll cite you when we use your slides. But thank you Thank you very, very much.